Hi, this is Brian Kim. I'm going to share with you this case of a patient who has aphakia and significant iris tissue loss. And so I'm going to hopefully illustrate to you why my modifications to the Yamane technique are superior to the original Yamane technique. Now, of course, I respect Dr. Shin Yamane tremendously for developing this innovative technique, but obviously he is a master at this technique. And for everyone else who is doing the technique, we really need to find other ways, other cheats, other hacks to figure out an easier way to perform the technique because you don't want to damage the haptics, you don't want to damage the lens, you don't want to lose the lens inside the eye. And so whatever can flatten the learning curve is really quite important for everyone else who's learning the technique. And for me, this case illustrates perfectly why my modification works so well. It's a patient, again, who has aphakia and significant iris tissue loss. With the original Yamane technique, you actually deliver the leading haptic into the angle. And then you go ahead and do the left side and placing the needle through the sclera and then cannulating the haptic into the needle, the leading haptic, and then doing the trailing. But you can't do that if there's no iris to place the leading haptic. And so this is why I think my modification works so well. So again, this is the Epsilon fixed caliper, 2.5 millimeters posterior to the limbus here, and then 2 millimeters adjacent. That's the other end of the caliper. We're going to go ahead and mark it ahead of time. Again, this patient is aphakic, already had vitrectomy. I'm using the cannula to find 180 degrees apart, and then I'm marking the limbus here as well. Again, it's pre-marked, the cannula tip, which makes it quite easy to do. And again, the fixed caliper here has also been marked. Again, 2.5 millimeters posterior to the limbus and 2 millimeters adjacent. I'm placing my limbal incisions for the procedure now. And this is the contralateral limbal incision to externalize the leading haptic. And then this is the incision for the AC maintainer. I'm going to fill the eye with viscoelastic, but as you can see, the viscoelastic just falling into the vitreous space. Again, this patient's been vitrectomized already, but this is my attempt to coat the corneal endothelium with viscoelastic. Using the cannula to hold the eye, I make my incision. Again, it's 90 degrees away from my marks, and this is a 3/0 blade. Placing the 20 gauge AC Lewicky maintainer, and this is a 30 gauge thin wall needle. This is the right side needle first, bending it 9 millimeters from the tip. And this is the left side needle. I'm going to bend it at the hub. Again, the direction of the needle is going to face the haptic. And this is a 25 gauge needle, again, faces to the left, which I use to guide the leading haptic out of the contralateral limbal incision. So this is the 3-piece sensor lens. I'm going to place it into the cartridge there. You want to make sure it's seated down. And as it's seated down, you can feel it's down. Both edges of the optic are down. As I'm pushing it, you want to make sure the leading haptic comes out straight. Place it into the injector. You want to make sure the trailing haptic is out of the way here. You can see it's sticking out right there. You can see it's sticking out from the barrel. You want to make sure the plunger does not touch that trailing haptic, and when you push it, it starts to internalize. Now here we go. I have the 25 gauge needle contra-incisionally. My assistant is delivering the leading haptic. I ask her to stop, and I'm going to try to direct the haptic towards the needle. If you don't have them directed quite evenly, you might slip, but that's fine. You can see I'm able to direct it out. And then I take over, deliver the optic. This is a gentle technique of externalizing the leading haptic. push some more cohesive viscoelastic to coat the cornea. And the AC maintainer is on. I place the needle from the first mark to the second mark, dive down, make sure you clear the ciliary body. And very gently here, you want to make sure you push the optic away a little bit so I can get that trailing haptic. Very gently placing it in. You don't want to bend that haptic. And then very carefully docking the haptic on the bevel of the needle. Again, the haptic is facing towards the bevel of the needle. The bevel of the needle is facing me. And very easily just slides right in. No traction, no force necessary. It just comes down to flattening the haptic and then pushing it on the bevel of the needle, and it goes right in. Doing the same technique on the right side, but look here, I place the needle through the sclera on the right side, and then I externalize with microforceps without doing it as a two-step maneuver. This is more like a one-step maneuver. Again, I have the needle in the eye, I internalize the leading haptic, and then I go straight to cannulating the haptic into the needle. Again, why did I do it that way? Because I don't have iris as a platform to place the haptic. And this is why this technique works so well in this particular situation. I'm able to pull that haptic out, cauterize the tip, and then I'm do the same thing on the other side, making sure I have forceps ready so the haptic doesn't slip. I'm pulling the needle straight back away from me. This makes sure that there's no damage to the haptic. With the sensor, it doesn't tend to slip back in the eye. That's what I've noticed. And there's another reason why I like the sensor over the C2 Lucia. It doesn't tend to slip back into the eye. Pushing the haptic flush to the sclera here. So again, if you pay attention to what I showed you here, I placed the needle through the sclera on the right side. The leading haptic's already outside of the eye. And why do you have to do that? Because it doesn't have iris as a platform to place it into the angle here in this patient with no iris tissue. So I was able to use microforceps to pull the leading haptic into the eye and then directly cannulate the haptic into the left side needle. Really slick, really efficient, and it's just kind of a one-step maneuver. And by doing it this way, I don't have to worry about placing the leading haptic into the angle when you don't have an angle. This is really a very efficient way to perform Yamane the way I modify it in the setting of aphakia and no iris tissue. I saw some very fine wisps of vitreous, and so I decided to place the trocar in. You want to tunnel through the sclera and then dive down. When you do it that way, you'll have a self-sealing sclerotomy. And you know this because the trocar tends to sit a little sideways. That means you have a really nice tunnel to your sclerotomy incision. So again, I'm performing vitrectomy and using the cannula to check to see if there's any vitreous. Again, not much vitreous because this patient's already been vitrectomized, but I'm just checking here. And there is some, again, some vitreous here right at the incision. Not a whole lot, but there's some. Pushing some viscoelastic through the main incision to make sure that there's no vitreous at the end here. And then I'm going to go ahead and tie down that tenonylon suture. and then I'll bury the knot, and then more vitrectomy again, just to make sure there's no vitreous to the wound. This is some intracameral triamcinolone. No obvious vitreous here. I'm going to go ahead through the trocar and remove some of that triamcinolone and clear that out, and then going through the limbal incision to remove any potential vitreous strands. But again, it looks pretty clean here. And then at the end here, I'll hydrate my incision. So again, this is a patient who is aphakic, no iris tissue. Again, with the traditional Yamane technique, you normally place the leading haptic into the angle. Of course, in order to do that, you'd have to have iris tissue. This patient did not have iris tissue. So I was using the trailing haptic first technique, externalizing the leading haptic, again, using a guide with a 25 gauge needle to dock it and then slide it out. Again, an achromatic technique, using the sensor lens, which has very delicate PMMA haptics. And then I'm able to go ahead and tackle the right side needle going after the trailing haptic, which is made easier because the leading haptic's been externalized. I'm able to place the needle through the sclera on the right side and then internalize the leading haptic with microforceps and then directly cannulating the haptic into the needle as a one-step maneuver. By doing it this way, I don't have to lay the haptic on the iris or angle. In this case, there isn't any, so it would be quite a challenge to do it that way. And this just bypasses that potential problem. So again, when you're dealing with a patient who has no iris, I feel like this technique is superior for sure because you're able to externalize the leading haptic through the contralateral limbal incision, and this patient did quite well. So I hope this was helpful to you, and I thank you for your attention.